Welcome back to another episode. I just grit through it.
What is most pressing to the
Really horrible.
You're getting married.
Other conditions.
Different things that
Normal changes.
Welcome back to another episode of Is This Normal, Doc? The podcast where we talk about what's normal and what's not with the expertise of our Tanner Clinic providers. As always, I'm Hope and I'm your host. Today joining me as my co-host is Chelsea. And our guest for today's episode is Dr. Rees Checketts. He practices metabolic and obesity medicine. I'm going to give him the opportunity to tell us just a little bit about himself.
Thanks, Hope.
Yeah.
I'm a local boy. I actually grew up. I went to Layton High School, graduated in 2011.
Same. We actually went to high school together. Fun fact.
Still not sure what a Lancer is, but that was our mascot.
It's kind of like a knight, I think, but different a little.
Went to Utah State for my undergrad, and I studied nutrition science there. And then for medical school, I was in Texas. Residency was in Nebraska for internal medicine.
Okay.
And I just came back to Utah this last year to do a fellowship in metabolic and obesity medicine. And so I am very excited to be here and to be back in Davis County.
Yeah, we're so excited to have you. He's going to start in August at Tanner Clinic, so we're really excited. We've already heard great things. He's already making a name for himself, so having you actually practicing at Tanner Clinic is going to be so awesome.
I hope so. I'm excited. I'm excited to be part of the team.
So today's episode, we're going to be talking about weight loss, which is what you do.
Yep.
But we wanted to do more of a focus on weight loss along with some common comorbidities that people also struggle with. So how to do that safely. This is going to be a great topic for people because I think they always wonder what's the first step or what do I need to deal with first? Like I can't go off these medications, but they're, affecting my weight loss. So I think it'll be interesting to talk a little bit about that and some of the things that you recommend for people with comorbidities while they're trying to lose weight. But first, we have to start with our favorite segment that we like to call, Is This Doc Normal?
No, I'm not normal.
That's okay. But actually, I probably think you are. I don't know. Most
so.
people are a lot more
I feel
normal
like-
than they think.
yeah.
Okay. Our first question that we ask everybody, and I'm going to ask you the same question, is who is your favorite fictional doctor?
So there's definitely, I know his real name. I forget his stage name, but Noah Wiley on The Pit.
Oh, yeah. Mm-hmm.
He's amazing. And that show was incredible. It was as real life as I've seen in a medical
Yeah.
show, just the insecurities and the way that he goes through and navigates. Rock star, loved watching him. But then I'd also have to say Doctor Strange.
Okay, you're the
Who? I
third
was gonna say.
I mean,
People
time
love
travel, sorcery, and neurosurgery.
Yeah.
It's the trifecta. It's amazing.
He's like a doctor, but also with superpowers.
Well, he's like an
so-
amazing doctor.
Yeah.
I have huge respect for neurosurgeons. When I was in residency, they were the ones who were doing incredible work
Yeah.
at all hours of the day and night. And that's Doctor Strange.
Yeah.
And then he can do cool things with his mind. It's amazing.
But back to the pit, though, as someone who does not practice emergency medicine and has never been a doctor, what the heck? That's crazy. I'm like, this is too real.
I know. I can't ever binge The Pit. I have to watch an
You have to
episode
watch it
and
a
then
little bit at a time.
decompress and then
Well-
watch another one.
It's wild because you're watching those episodes and it's taking you through an hour of the shift.
Oh, yes.
There are some embellishments because it's TV, but there's a lot of really accurate things that are happening there. And those are real life cases that do come up. Hats off to our emergency doctors because they do tough work.
Mm-hmm.
Okay, if you could go pro in any sport, what would it be? And I mean any sport, you could say LARPing.
Is that a sport? I
Sure,
thought that was a hobby.
I'm sure some people can consider it. Or
Hobby
stick
horsing.
horse riding.
Yeah, hobby horsing.
Yeah, hobby horsing. You could say whatever
You have
want.
long legs. You could do great.
Quidditch. Just kidding. That's not a real sport. Maybe basketball. Loved basketball. I've always been a fan. I try and use my height and lankiness to my advantage. I developed a love for rugby, actually. Lived in Fiji for 2 years. And for a very small island nation, they are super good at rugby. And so that was a fun sport to learn more about, and I continue to be a fan.
Our last would you rather question is, would you rather not be able to control your laughter or not be able to control your tears. Obviously in certain situations, both would be bad. What are your thoughts there?
Yeah, there are times where both would be really bad.
Yeah.
It'd be nice if you couldn't control your tears at a funeral. It would be really awkward if it was like a grocery store grand opening.
Maybe they're tears of joy. Maybe you're really excited that Syracuse Costco just opened up.
Yes, I am. I think I would probably pick unable to control your tears.
I think so too, because you definitely could maybe spin that in like, I'm so happy I'm crying type of way. Otherwise, you just bring people down.
Well, like think about you're at someone's wedding and you could be like, oh, they're tears of happiness. Like if you're laughing while they're doing their vows, that's probably...
They would be like, that person is so disrespectful.
Yeah, like I just feel like laughing could come off a lot more disrespectful.
Well, and it depends if it's a chuckle or if it's like a really loud laugh.
Like a cackle.
Yeah.
Because if it's a cackle or it's an obnoxious laugh, then everyone will know that.
What if every laugh is an obnoxious laugh? I think that every time I edit this podcast. I'm like, maybe don't laugh anymore. Well, you know what? Honestly, you are normal. So good for you. I always say people do prefer a normal provider to a non-normal one usually, unless it's like they're really funny in a weird way. But
okay, good.
So we're instilling confidence in people, I think. So you're normal.
Normal doc.
Congratulations.
Okay. Thank you.
People can go see you with confidence. I think we should get into today's topic. We have a lot to cover, a lot of comorbidities that people deal with that we want to address.
Yeah.
So I think a big one is heart failure, and I think a lot of people want to lose weight to assist with their care.
Yep.
The first question I have is a lot of people want to know what the limit is with exercising. If you have heart failure, you don't want to exercise too much.
Yeah.
So what is your recommendation with exercise for someone with heart failure that's also trying to lose weight?
That's often where we identify that heart failure is present, is that someone will have limitations in their exercise. And they won't tell you, I have heart failure, I can't exercise. It will be, what do you do for physical activity? And they'll say, I'm really lazy or not much. And as you press them, they'll start to tell you, it's really hard for me to catch my breath. And they will immediately downshift into, because of my weight. And if you press them and you ask some of the questions, you'll identify this as heart failure. Just a quick overview of what heart failure is, and especially in the context of extra weight, is as someone's body increases in volume, their heart remains about the same, but it has to perfuse all of the different portions. And so the heart has to make adjustments to get all of that extra volume while maintaining the same capacity and size.
Yeah.
And one of the adjustments that happens is the kidneys and the hearts will start to hold on to fluid. And that fluid is going to bathe bathe the lungs. And that's usually where the problem is. And so people can't breathe and they feel like they're underwater because they have fluid that's in the spots where they're trying to get air. Yeah. So what do you do with exercise? As long as someone doesn't have chest pain while they're walking or doing exercise, they're probably okay to do an exercise program. Cardiac rehab is amazing.
Okay.
These are experts who are very good at helping people build their confidence to know this is safe and this is the amount that I can do. And then you just apply yourself. Exercise doesn't need to be fancy or exciting. It's something where you take what you can do and you push yourself close to failure, and you do that consistently over time. And that's where you build fitness and strength.
I don't really think I understood what heart failure was. So thank you for that.
You're welcome.
First off.
Happy to help.
Is that something that you can reverse?
You can do a lot to really help with it. So sustained weight loss is very helpful. We have medications that are pretty good at targeting that pathway. The kidneys and the heart, they don't talk together very well. There's an old sitcom. I always forget the name. I think it's Lucy and Ethel, or they've got the chocolates coming down the line.
Oh, just the Lucy. Just
I love Lucy. They've got the chocolates.
Yeah.
And they're told if you miss one chocolate, you're going to lose your job. And
And they start, like,
and
putting
as
them
they,
in.
so they start eating them, they start sticking them in their shirt, they stick them in their hat. They're just putting it everywhere they can. I think of that with heart failure.
Okay.
That's the heart and the kidneys. And the kidneys get overwhelmed by the fluid that starts to accumulate in the body. And so they just tuck that fluid anywhere they can. So you can do things that will help reduce the fluid, which is where people experience those symptoms. You can do things that can protect the heart from changing shape, cardioprotective. And then you can do things that can help people build and maintain their quality of life. And so there's a lot you can do to stabilize and reverse. Can you get all the way back to normal? It depends.
Is there like any risk with losing weight too fast?
There is a condition called cardiac cachexia. And what that is unintentional weight loss. Unintentional weight loss is always bad, even in my clinic. If someone is losing weight rapidly without trying, that is a red flag.
Okay.
In any medical course, that will be a red flag. And so if someone is losing weight very, very quickly, that could be bad. Far and away, what will happen when someone comes in and they're losing a lot of weight quickly with heart failure is it wasn't identified and we started to squeeze the fluid off. And so suddenly they get liters of fluid off. And I've seen people lose 40 pounds in a matter of days just by getting that fluid off. Those were inpatient cases, but it can be dramatic.
Yeah.
And they feel better. They can walk. They can move. Their legs aren't these sacks of water that they carry around. So it depends.
How do you balance fluid intake goals while losing weight?
Really good question. And the research is shifting on this one. We're starting to think that the fluid intake itself might not be as important as we previously thought. What I counsel patients with is I tell them that sodium is the key. Sodium is a water magnet. Wherever sodium is, water will follow, independent of the fluid on the body. And so we want people to stay hydrated and we want them to continue to drink. We used to say 1.5 to 2 liters per day, but what we're seeing is that if we focus instead on the sodium and we let people drink, not excessively, we're all trying to get about 2 to 3 liters at least per day. If we're watching the sodium, which is that water magnet that keeps fluid on the body, then we tend to be okay.
With some of the new, I don't know if they're new, but they're new to the public.
Yeah.
I'm sure they've been around for a long time, but just all the trending weight loss medications, do those help keep the heart safe? Or I don't know, is that a myth? I guess I think people have maybe said that.
I feel like I've heard that certain weight loss medications can put you into heart failure.
Right. So one of the oldest medications was phentermine. And this is one of the, at the time, most effective weight loss medications. And it is a stimulant type medication.
Okay.
That's not good with any heart condition. And so that's one to be avoided. We have other ones that can help, like topiramate. There's Wellbutrin, which is an atypical antidepressant. These ones don't have as much effect. Wellbutrin a little bit, it can maybe increase the heart rate. The ones that everyone knows about these days are the GLP-1s. Those ones are heart protective.
Okay.
Which is amazing. We're seeing benefit. It reduces risk for heart attack. It is showing some signs of helping with heart failure as well. And so those ones absolutely are safe for the heart and something that I reach for if someone has heart failure.
Is there anything that you would tell someone with heart failure that's trying to lose weight? What advice would you give them about weight loss?
The first thing is we need to get the fluid off. We need to stabilize this condition, name it properly. We need to evaluate the severity of it. And then we need to come up with a plan. 1, to get the fluid off. And 2, how are we going to build your quality of life? Oftentimes people's exercise tolerance is reduced. And so even basic activities like picking up their groceries is a challenge for them. So how do we get you back into living life? And then we can go. And so sometimes if someone comes in and in the first visit, we identify that they have a very significant portion of heart failure, I will forego any of the weight loss focus and I will just focus on how do we get you feeling better so that you can go live life. They come back and they feel dramatically better and they're ready to conquer the world.
Let's address that first
Exactly.
and foremost. And I think that's good to know, because I think people are just like, well, I want to lose the weight.
Mhm.
Well, you have to address these things first before you can even
Right.
do that.
And the other thing to keep in mind is that weight is one number in our toolbox. And your body weight, it's a reflection of gravity's pull on your body.
Mm-hmm.
And that correlates with the amount of weight that you have on your body. It doesn't tell us where the weight is, if it's muscle, fluid, bone, blood. And so if people have a lot of fluid on them from heart failure, they can lose a lot of weight and not have any of their fat stores change.
Yeah.
So the goal is fat loss in my clinic. Weight loss can come through a variety of things.
Yeah.
And losing fluid does help with the weight, but it's not usually the weight people are going for.
Yeah.
Can losing weight reverse fatty liver disease and scarring on your liver?
Fatty liver disease is, we're learning so much more about. We used to think that all liver disease was from viral hepatitis or from alcohol. In the last few decades, we've realized that metabolic components play a big role in that. Very quickly, it has become the fastest chronic liver disease. The most prevalent worldwide is metabolic liver disease. What happens with that is that fat droplets begin to accumulate within the liver, and they may or may not cause inflammation. If they cause inflammation, that can progress to scarring, which can be irreversible if it goes on long enough. And so to your question, yes, you can reverse it if you catch it early enough, which is exciting because we didn't always think that. But I have seen that numerous times, even in just 12 months of paying close attention to that. You can reverse it if you start early. And again, these GLP-1 medications are super effective for that.
So we talked about weight loss medications for, are they healthy for people with heart failure? But now we're talking about liver disease. Same question. Weight loss medications, are they safe for people with fatty liver disease?
Yeah, so luckily, when I look at my toolbox and the medications that I have available, almost none of them need to be adjusted for liver impairment, which is really good. And it makes my job a lot easier. With that, sustained weight loss is the best treatment for fatty liver disease, especially metabolic fatty liver disease.
Mm-hmm.
Any form of sustained weight loss, no matter the medication, can be helpful. We are seeing in the study that there's 2 medications approved specifically for metabolic fatty liver disease with scarring. One of those are the GLP-1s, and the other is a thyroid type medication that acts directly on the liver. That second one doesn't induce weight loss, but the GLP-1s, they do reduce the inflammation, they resolve the fibrosis, and they help sustain weight loss.
Okay. I don't know what your process is with like diet, I think it's probably different for everyone, I would assume.
Right, yeah.
But a lot of times when people are trying to lose weight, a lot of people recommend like high protein for people with fatty liver disease. Can that cause any issues if they're trying to eat like a high protein diet?
Generally, no.
Okay.
The things that cause a lot of issues with fatty liver disease, alcohol, sugar-sweetened beverages, diet sodas, there's very vocal camps. As I look at the research, and they've done studies, long-term, a year or more studies, where they've given people a sugar-sweetened beverage, think soda.
Yeah.
They've given them a diet soda, and they've looked after a year, and the people on the diet sodas lose weight and improve their insulin sensitivity. Then they took a similar cohort and they did a diet soda and water. And after a year, the people with the diet soda improved their insulin sensitivity and lost weight compared to water.
So my diet
That's not what I'm saying.
is great for me.
Water is still the best, but there is evidence
Yeah.
to support that, diet sodas can be a great harm reduction. The things that are very harmful for the liver: alcohol, sugar-sweetened beverages. When you get that bolus of sugar, and especially when you drink it, it goes right into your bloodstream, raises your insulin, and that just goes right into processing. If you have insulin resistance or too much insulin present, it tends to get stored almost immediately in the liver. Unfortunately, we have not evolved to process fructose like other animals. So I always say protein and produce together.
Yeah.
Those 2 things will help you to fill full so you're not just tormenting yourself, reduce your calories, and over time that brings sustainable weight loss.
Okay. I'm wondering if people are wondering about like red meats or like high fat meats. Do you tend to tell them to stay away from those types of
I have gone
like
all
lean
over the
proteins?
place on my career.
Uh-huh.
And we do know that red meats, they're high in saturated fats, and that those can be harmful for the heart. They can increase inflammation on the body and promote atherosclerosis. And so we do want to limit those. Having said that, a lot of the problems that I see in my clinic is just people are getting a lot of sugar-sweetened beverages. A lot of people come in and they're drinking a lot of soda. And
They're 44 ounce from Swig.
yeah, Swig's not going to sponsor me. But a lot of people are, and they're going to Maverick or whatever gas station, and they're getting a 2XL soda that they sip on throughout the day, and that's really, really hard metabolically. If we can move from that playing field to the next level, we want to be whole foods. We want plant-based. We want to focus on vegetables, fruits. You can overdo fruits if you have fatty liver disease. It's not something to just fill your plate 3 times a day with just fruits. Mm-hmm. Have some. Let that be your replacement for treats or candies and things like that. The protein sources themselves, I don't worry as much about unless someone is really looking for other options. Does that help?
It's very helpful.
Will rapid weight loss cause gallstones?
It can.
Hey.
So rapid weight loss for a variety of reasons can cause gallstone formation. The thought process is that when you lose weight and the fat stores release their energy, that goes back into the bloodstream, and that the cholesterol that's part of those adipocytes, which are the fat cells, and the cholesterol from the adipocytes can be released and concentrated within the gallbladder. But there is a medication actually that's very well tolerated that we can give to people that can help them reduce the risk of having their gallbladder removed. It's called ursidiol. I make a practice of discussing this with my patients and letting them know if you're losing more than 10 pounds in a month, we need to be taking this. If you are going to go see a bariatric surgeon, they will almost automatically start you on this at the time that your surgery is completed. So rapid weight loss can be a risk.
I kind of want to talk a little bit about sleep apnea. I'm going to show how I retain information from this podcast, okay? When you watch this podcast, you learn stuff. We had some of our sleep medicine providers on, and they talked a little bit about sleep apnea and how weight does have an effect on it because of the volume around this area can obstruct
Right.
whatever that is, okay? I'm not a doctor, but I got some of it. So the volume here affects sleep apnea.
Absolutely.
So when you lose weight, I'm assuming that can help with sleep apnea. But for people who are experiencing sleep apnea, I think it can be harder to lose weight because of the lack of sleep. So what is your protocol there for people with sleep apnea?
No, you nailed it right on the head. That's exactly right. So sleep apnea is a vicious cycle. Poor sleep quality or quantity affects our metabolic health. If we're not getting enough sleep, then the next day, even just one day, but especially over time, the levels of our cortisol increase, our hunger hormone, which is ghrelin, increases. And so we can develop some significant appetite and hunger the next day. Compound that with, as the cortisol goes up, insulin resistance increases. That makes it difficult for us to release the fat from our fat stores. So sleep apnea is something that needs to be looked into at the first visit. Yes, sustained weight loss helps, but sometimes we have to start treating the sleep apnea to get that process going. Treating it, and it's very challenging because you've got a foreign object coming at you if you require the PAP therapy. And that is scary and overwhelming to people. But a lot of the times people will come in and they'll tell me, I had no idea how good I could feel. And that's when I know that they're actually wearing it. And then we'll start to see things get better. And they say, I can function better at work. I have more energy. I feel so much better. And that's when we know that we're doing the right thing. When the weight starts to come off, we know that we're at least taking care of one of the biggest undermining factors, and that's poor sleep.
And would you say that once the people do start to lose weight, are they able to like go off their CPAP machines? Or is that kind of different with everybody?
It's different with everybody. We know that a 10 to 15% body weight reduction, that's a criteria to go and repeat a sleep study. These days, a lot of the machines are really good at auto titrating. And so they'll reduce how much pressure that they give you.
Yeah.
And so you're able to sleep comfortably, and the settings will adjust as your need reduces. Some people are able to come off. Some people see a significant improvement in their requirements. It really depends, but it does tend to get better. Not everybody comes off of them completely.
No.
But hopefully they learn to really appreciate the benefits that come from it.
How will weight loss drugs affect other medication that you're on? Like for high blood pressure, for insulin? Does that have an effect on those other medications, or are you fine to still take them?
Yeah, so it depends on the medication itself. For example, if we are doing a GLP-1 medication, that makes your insulin more effective. It's pretty interesting. They've even given GLP-1 medications to persons with type 1 diabetes, and they are dependent on insulin. They cannot survive without insulin, but when we do that, we see a reduction in their insulin requirement because the insulin that they receive through the pump or the injections becomes more effective. That's one that we absolutely have to be aware of, is if you're on insulin and we start one of these, almost by 33% at least, we need to reduce your insulin. Also very exciting because insulin injections themselves can promote weight gain. And so we can eliminate one of the common medications that people need to have that can be contributing to their weight. As the body weight decreases, a person's blood pressure tends to decrease. We talked about heart failure earlier, but if that is the case, you take some of the extra fluid that's in all of the blood vessels off of the body, and that helps reduce the total blood pressure. There are other mechanisms at play and other proposed theories. Losing weight does reduce your blood pressure, so we have to keep our eye on that as well. That's one of my favorite things to do, is to deprescribe medications. And so when we start losing weight, I want to coach them and say, these are things to look for. If you're getting lightheaded frequently, you need to let me know. I want you checking your blood pressure at home, and if it's starting to trend down, this is a good opportunity to reduce or eliminate some of the medications you're on.
What about blood thinners?
There is some research that it can help, but I'm not as familiar with that. As a rule, I just tell people to continue them.
So GLP-1s, are they a type of insulin?
No.
No. Okay.
They're not. So GLP-1 medications, they mimic a hormone within the body. We have incretin hormones that are released from our intestinal tract in response to food. Food gets into the small intestine, it signals the release of the incretin hormone, which activates the GLP-1 receptor. And so GLP-1 receptor agonist, which we shorten to GLP-1, is really just the incretin hormone. The effect that has is that it makes your insulin more effective. Yeah. We have modified synthetically and manufactured at length that GLP-1 hormone so that instead of being degraded within the 2 to 3 minutes that normally happens in the body by a different enzyme, sorry, we're going into lots of deep physiology, but instead of being degraded, it will remain persistent for a day if it's an oral pill or up to a week if it's an injection. So it's not insulin, it's a synergistic effect that mimics kind of natural physiology.
I know another kind of like drastic form of weight loss is doing bariatric surgery. I know not everyone is a candidate for that. Who would you recommend? Obviously, let's recommend they go see you first before they make that decision. But who would you point towards bariatric surgery as a good option?
Bariatric surgery is, in my mind, it's very underrated. I wish I were capable of doing that. It's a very different pathway. It would take another 7 years of training. My wife would not let me do that. And so it's a long route to become a surgeon. But the tool of bariatric surgery is amazing. When we do studies and we compare weight loss through diet and lifestyle, GLP-1 and surgery, oftentimes with the current GLP-1s that we have, surgery remains the gold standard. And so surgery, the criteria is actually very generous. The people who qualify, there are quite a few. because one, it's very safe. We have now got it down to the same risk as having your appendix removed or your gallbladder taken out. Those benefits are implanted underneath your skin for life. It doesn't matter what your insurance coverage does. Copays are not an issue. It is a procedure that you get once and then you get those benefits. So yes, please come see me before and we can talk about what we need to do to get ready for it, because it is an ultimate and a final measure. It's not something that we can undo. If your BMI is over 30 and you have metabolic disease, you qualify. Whether insurance will cover it at that point is kind of a gray area. They usually are starting to do a BMI 35 or 40. It's actually a quite generous criteria. Most people come and see me because they want to avoid it at any cost. And that's fine. And I'm happy to work with them, but it is not uncommon. And we're actually seeing some increasing rates of some of these surgeries in the last few years because people are coming in and they're having that conversation. They're feeling like they're getting the right information in the right tone. And someone says, hey, you've tried everything and you're okay, but we're not where we need to be for your health. The conversation flips and people often will go get it if they need it. The vast majority of people who meet criteria are not receiving surgery, but it remains a very good option.
I don't think people ever really talk about it. They just go straight to the GLP-1s.
There is so much shame around weight loss. We ascribe all sorts of moral characteristics to weight. And some people will even say this is an outward manifestation of your inadequacies. That's just not even true. Like, there's some things that we can control. We all know that the foods that we eat make a difference in our metabolic health, and that can contribute to metabolic disease and our weight. But then there's all of these other things like the medications, your other medical conditions, your income, your ability to get sleep. All of these other things contribute as well. And so with all of that stigma in mind, when everyone's watching you and they're all thinking, this is because you are lazy or because you're gluttonous or whatever else, there's a lot of shame. And so people want to do it quietly. GLP-1s are much less visible because surgery, you come out and you have a modified diet for about 3 months. You do not feel great coming out of it. And then you start to lose the weight. And within about a year, most people are really happy they did it. But it's much more difficult to keep that concealed in your refrigerator taking once a week.
What side effects would make you take someone off their weight loss plan? Like, are there big side effects that come with doing GLP-1s?
GLP-1s, so effective. What they do is they slow the stomach motility. So the most common side effects are constipation, nausea, diarrhea, and vomiting. These often guide me. I'm always trying to keep someone on the smallest dose. The goal is to improve the metabolic function of your body, right? We want to make the insulin more effective. We want to help with the heart protective benefits. We want to give the liver that edge against metabolic disease. When it comes to weight loss, we want to help you appreciate a calorie reduction. And so these mechanisms help slow down someone's need to eat, and they feel like they can get by with a smaller amount. A lot of people who struggle with extra weight without realizing it, they have genetic signals that tell their body to stay in a hunger zone. And so most of us, we have hunger and we have full, and then there's satiation, which is in the middle. I like to say it gets sticky. There's a lot of genetic things that make that middle zone sticky for people with extra weight. And these medications will help with that. So it's like an equalizer. It provides your biology with that signal so that you are able to say, you know what, I do feel satisfied, to give yourself permission and not feel like you have left the table and you're still hungry, because that is a real thing that people struggle with. So side effects that would make me take someone off if they stop eating. We want to blunt, not eliminate the appetite. If you lose your cues to eat, that is a problem. Food is fuel. We have to eat. We want to eat. We want to improve the quality of the food that we eat. But if you lose your ability to eat completely because you feel nauseous, we either need to go down on your dose or we need to find a different medication. If someone is not able to engage in those resistance exercises, I become extraordinarily concerned about their body strength and function. And that's something that makes me concerned. We need to reevaluate things.
So when someone is on a GLP-1, they get to a more healthy state. Do you take them off? Are they on it for life? What is kind of their game plan from there?
What we found, this was a real life study, is that when people would come off of the medications, if they continued treatment, they were still following with someone that was checking in on their diet. They were still moving. Maybe they switched to a different medication, a different GLP-1 or something else that helped with sustained weight loss. We found that they were able to maintain at almost a 50% rate, and some even lowered their body weight still. The trial data is very different. The trial data, they would put people on, they would titrate it aggressively. Every few months they would go up, and they would try and get people to the maximum dose as soon as possible. And then somewhere halfway through the year, usually within the first 20 weeks or so, they would switch them to placebo. Those people would see a dramatic weight regain, about 2/3 of their body weight. All of that to say, it really depends on the individual. I am a fan of these being continued as long as possible because of the heart benefits, what they do with the sleep. They help metabolically, and they're just very, very useful. Some people do not require that, and their metabolic health can improve, and they're able to maintain their weight with a reduced dose or to come off. But in general, most people are going to require some dose, if not to continue at the highest dose. It really just depends.
We've learned a lot. This has been a great episode.
Okay,
I want to
good.
give you the opportunity to give us one last overarching thought about, losing weight with comorbidities. What's something that you really want to push about weight loss with comorbidities?
Right. So the goal in my practice is to improve your health. Oftentimes, very, very many of us that struggle with these comorbidities is because we have extra weight. And so we want to do both. We want to target the comorbidities and build the right plan so that you can live a fulfilled life free of some of those pesky side effects. But then we also want to move the needle on improving your health so that you can live longer, feel better. And so it really is a complex process. That's what I love about my job, is to see the person in front of me and to make a plan for them, and then to watch things progress and to see the results start to accumulate.
Thank you so much for coming and
Yeah.
educating us on not only weight loss, but healthy habits, really.
Right.
Forming those healthy habits and becoming a healthier person overall, because weight loss is just one part of that.
Yeah,
And that's
exactly.
a big thing that I've learned today is weight loss can help, and it can also not be the only issue. So I think that's really helpful for people to know. So I appreciate you coming on here. I want to give you the opportunity to let people know where they can find you
Yeah.
you're very big on social media. So where can people find you?
I started on social media a few months ago trying to help answer some of these questions. I'm on every platform: Instagram, Facebook, starting on YouTube, and a little bit on TikTok. I'm at Dr. Rees Checketts on all of those platforms. I'm trying to address these common questions. They come up often, and then to provide some behavior first change that people can employ today that will help improve their health.
Being the source of truth on the internet, really, which is great. Maybe a little, is that too much pressure for you? Or
No. I really hope to be that. I don't know if this is the right setting, but I'm trying to create a guide for people that they can almost troubleshoot their way through weight loss if they don't feel like they were getting the questions answered in between. It's not possible for me to see all of the people that have questions. I wish I had the capacity to do that, but I'm always trying to find ways that people can get those questions answered safely and accurately.
Yeah. For everybody watching and listening, Dr. Checketts is going to be joining Tanner Clinic in August. So hopefully by the time this episode is up, his schedule will be open so you can start scheduling appointments. So I highly recommend that you do that if you are wanting to become the healthiest and best version of yourself and you don't know quite how to do that. I highly recommend making an appointment with him. We are going to do 2 episodes with Dr. Checketts, so stay tuned for our second part. We're going to talk a little bit more about the psychological side of weight loss, which I think a lot of people struggle with. That's one of the biggest reasons why people struggle losing weight. So if you want to learn more about that, please look out for that next episode, and we will see you next time.
Bye.